The topic for discussion today is salivary gland diseases. As you all know, and general surgery in context with dentistry also deals with various disorders affecting oral cavity, head and neck parts. Especially one of the important thing that as a dentist we deal with is salivary glands. Okay, the various salivary gland diseases like both neoplastic and non-neoplastic. Most commonly that we encounter are non-neoplastic, and other conditions that we see are tumors. Okay, so when we're talking about the salivary gland diseases, today let us discuss about. I will not go much into the anatomy or the anatomical features about it. We'll directly go into the various pathological factors of salivary gland diseases. Okay, for a brief introduction, as you all know, salivary glands are of two types. One is major salivary glands and minor salivary glands. Major salivary glands are again parotid glands, submandibular and sublingual glands. And these glands are usually occur in pairs, like we have two submandibular, two sublingual and two parotid glands, right? And we have many other minor salivary glands, okay? And these minor salivary glands usually are most commonly seen in the lower lip, in the palatal region, and sometimes in the buccal mucosa also. When we're talking about salivary gland diseases, these diseases can either affect your major salivary glands or minor salivary glands. However, the major salivary gland diseases are apart from the non-neoplastic conditions. When we are talking about neoplastic conditions, major salivary glands are the one where multiple number of benign tumors occur, whereas minor salivary glands are the one where maximum amount of malignancies, malignant salivary gland tumors usually occur. When you're talking about these salivary gland diseases, they can be broadly classified as neoplastic conditions and non-neoplastic conditions. And non-neoplastic conditions, the first thing that we talk about are developmental disorders, and the various developmental conditions, developmental disorders that occur in salivary gland is one is hypoplasia or aplasia. This hypoplasia or aplasia, as the name itself indicates, is underdevelopment of the salivary glands or complete absence of salivary glands. That is nothing but your aplasia. So this hypoplasia of salivary glands can lead to dry mouth conditions or hyposalivation conditions. Aplasia, there will be complete xerostomia if all glands are involved. If one particular gland is involved then decreased salivation can be seen. Usually this hypoplasia of salivary glands most commonly we encounter in ectodermal dysplasia conditions. Okay, hydrotic type of ectodermal dysplasia, you actually see this hypoplasia of salivary glands. And other conditions in developmental disorders are accessory ducts. These accessory ducts is not particularly a disorder, but most of the people, 50% of the population have these accessory ducts, and these accessory ducts are usually allowing the saliva to flow into oral cavity in an ectopic place. If at all these accessory ducts are present ectopically, then it can pose a problem. Coming to diverticulums is nothing but pouch. Okay, it is like a outpocketing or pouch. Along with the ductal system, there can be a small pouch can be present. So with this pouch, what happens is when the saliva is flowing, little amount of saliva can seep into this pouch, and it can be stagnant for a longer period of time, giving rise to formation or posing a risk factor for calculi. So these are developmental disorders. When you talking about functional disorders, it can be either hypersalivation or hyposalivation. Silaria or tylism is nothing but excessive saliva production in the mouth, whereas xerostomia is dry mouth, hyposalivation is reduction in salivation. So this xerostomia can be a side effect either because of some drug induced xerostomia, especially psychotic drugs when patient is on antidepressant and or normal antihistamines also. Antihistamines also can cause decreased salivation. Okay, this can also be hyposalivation. So this is drug induced. And some kind of when we're talking about radiotherapy, especially if there was any carcinoma on the buccal mucosa or on the any bone carcinoma in the region of the salivary glands, in vicinity of the salivary glands, when patient is posed to this radiotherapy, what happens? Because of a side effect of this radiotherapy, there can be a complete fibrosis of your salivary glands, leading to decreased salivation. Sometimes it can lead to xerostomia also. And other conditions like any autoimmune conditions and any infectious conditions of your salivary glands, Sjogren syndrome. In Sjogren syndrome also we have hyposalivation. In extreme cases we can see xerostomia. In Mikulicz disease also there can be xerostomia. So these are various functional disorders which are usually associated with our salivary glands. And we have something called as obstructive disorders. Obstructive disorders means there can be some obstruction like along the duct or within your salivary gland. So this obstruction can be because of a caliculi. Caliculi is nothing but some stone. So salivary stone or salivary caliculi, also called as sialolithiasis. What does this sialolith will do? This sialolith will cause obstruction. See, for example, this is your duct and we have a sialolith here which is obstructing the flow of saliva. So with this what happens is there will be swelling in the region, in the proximal part of wherever the salivary stone is present. It can lead to, first is functional disorder, second is because of obstruction, there will be pooling of saliva there, resulting in pain or tenderness of the particular gland. And any growth, whenever this is the duct, any surrounding growth is present, this will cause collapse of the duct. In proper, there is no pathology within the duct, but because of the surrounding structures overgrowth, what happens is it causes compression of your salivary gland duct, resulting in collapse of your ductal position, also leading to obstruction. So for example, sialodochitis condition, it can be obstruction of your because of the external forces. What happens is the salivary gland duct gets obstructed. Next is sialidinosis. Sialidinosis is nothing but your non-inflammatory or non-neoplastic swelling of the salivary glands. Okay, most commonly seen in metabolic disorders such as diabetes mellitus, patients who are chronic alcoholics, and also in morphine addicts, and in case of malnutrition also we see this sialidinosis. And mucocele. Mucocele is again a retention or extravasation cyst. Usually, if it is a retention cyst, it is usually caused because of any salivary caliculi present or obstruction of the salivary gland duct. And it can also be an extravasation cyst. Extravasation because when patient is usually having some kind of lip biting or any other trauma condition, what happens is the salivary ductal wall can be broken or it can be breached, resulting in seepage of this saliva into the peripheral tissue spaces. This is nothing but your mucus extravasation cyst, also called as mucocele. Mucus retention cyst can be mucocele. Sometimes it can also be called as ranula if it is occurring in the floor of the mouth. And we have other inflammatory conditions. Inflammatory, if it is bacterial condition, we have bacterial sialidinitis, acute suppurative sialidinitis can be seen, and acute suppurative parotitis can be seen. If it is of viral origin, most common because of polymyxovirus, we have mumps, cytomegalovirus, we have HIV virus, and also allergic conditions. In case of allergy also, we see this swelling of the salivary glands or inflammatory conditions of the salivary glands. In case of sarcoid adenitis is nothing but one kind of granulomatous condition where the normal salivary tissue is been replaced with your granulomatous tissue there. Because of this, what happens? There will be decreased in the normal function, or there will be no proper functioning of your salivary glands. So this is nothing but your sarcoid adenitis. And specific infections. Some particular infections have affinity towards your salivary glands, like mumps, tuberculosis, actinomycosis, syphilis, etc. are the specific infections which has effect on the salivary glands. Next, we are talking about autoimmune disorders. In autoimmune disorders, as we have already discussed about Sjogren syndrome, about Mikulicz disease, these are some of the autoimmune conditions which will affect your salivary glands, resulting in decreased salivation. Next is neoplastic. Another broad classification which we are talking about is neoplastic. So we will be discussing some of the important conditions among this in the following presentation. Now, when we are talking about acute suppurative parotitis, this is usually a condition which is an inflammatory condition. As the name itself indicates, parotitis. Itis is inflammation of parotid gland, and it is acute suppurative. Suppurative is there is some kind of inflammatory reaction leading to pus formation. The most common organism that is involved here is your Staphylococcus aureus. Also, Streptococcus and pneumococci are also usually associated with this acute suppurative parotitis. So, what is the etiological factor? First thing is decreased salivary flow, and second thing is your partial obstruction. Because of any caliculi present or any sialolith that is present, what happens is the saliva production is normal but the flow is not proper. Because of this obstruction, what happens, there will be pooling of saliva at that region, and secondary infection happens because of this Staphylococcus aureus or Streptococcus bacteria, and this will lead to suppurative condition. So the clinical features is, it is an acute condition, so it has all inflammatory, factors associated with it, like patient will have pain, patient will have swelling, tenderness on palpation. The swelling is usually brawny swelling with induration present, and when we are nicely palpating it, we can see pus discharge coming out from the opening of your ductal opening by either by digital palpation or by manual palpation. When you are putting one finger within the oral cavity and other hand below the outside the mouth, the submandibular, if submandibular gland is involved, when we are nicely milking the gland, we can see that pus coming out from the ductal papilla, which is a clear indication of your acute suppurative submandibular gland infection. If you're talking about acute suppurative parotitis, similarly at the Stenson's ductal opening, when we're nicely palpating from outside, milking the gland, and from inside also we can see pus discharge coming out from the ductal opening. This pus has to be given for culture to check what kind of organism is causing it, and proper treatment can be planned. I mean, proper antibiotic can be selected for that organism. Coming to fluctuancy, when we're talking about clinical examination, normally this acute parotitis is not fluctuant. It does not have, it is not either compressible nor reducible. It has a brawny induration, usually firm in consistency and sometimes firm to soft in consistency. Tenderness is present. The swelling is usually diffuse. It is not well defined or not well localized. Usually the swelling is diffuse. Now coming to the management, as we indicate the patient, we have to give all the general precautions, like patient should maintain oral hygiene properly and take good rest. And when talking about antibiotics, proper antibiotic that is being suitable for the organism has to be given. Empirical therapy with penicillin can be given. Cephalosporins are also drug of choice there. And gentle parotid massage. As whenever you're talking about pus, remember this one single line: wherever there is pus, let it out. This will cause better healing. It will make the antibiotics or whatever medication we are giving to the patient act better. So gentle parotid massage will help in extirpating, or it will help in bringing out the pus that is present within the parotid to through the ductal opening. And drainage, hence if the swelling is very severe, then what we can do, we can give a drainage with Blair's method of drainage of parotid abscess. But very much important thing here is one should be very careful with the facial nerve, because facial nerve is very much in vicinity to the parotid lobe, anterior lobe of parotid. So when we are giving an incision for drainage, utmost care has to be taken to prevent injury to facial nerve. So this is about acute parotitis. Now when we are talking about acute suppurative parotitis, we have seen. Now when we are talking about acute parotitis, the only difference here is usually this acute parotitis is caused by viral organisms, but sometimes it can be because of bacteria also, where tuberculosis and actinomycosis are one of the common drugs. Usually this acute parotitis is bilateral. If at all it starts as unilateral also, within few days or within few hours to days, it converts into bilateral condition. This acute parotitis most commonly caused because of mumps, which is Coxsackie virus. I'm sorry, earlier I have told it as polymyxo, it is Coxsackie virus, and it is again divided into acute non-suppurative parotitis condition, usually bilateral as we have seen. Next we are talking about recurrent subacute or chronic parotitis. It is usually a sequelae of acute inflammatory condition. The most common etiological factor here is again obstruction, and it is an autoimmune condition. It resembles to Sjogren syndrome if it occurs both sides. So when we are talking about this subacute or chronic parotitis recurrent condition, one should keep in mind about Sjogren syndrome if the swelling is usually bilateral. The clinical features are pain is present, swelling, and with pus discharge can also be seen. Coming to investigations, we can do a normal routine radiograph, especially if it is involving parotid. We can do a puffed cheeked view, 10 degrees AP view can be done. We can also go ahead with xylogram or xylography, and this xylography reveals a punctate xylactasis. Ultrasound can also be done, Ultrasound will give us an insight whether it is a solid lesion or a cystic lesion, and it will also help us to know what kind of lesion it is there. And MRI is beautiful investigation, especially when it is coming to soft tissue conditions. And in salivary gland diseases, MRI will help us not only in identifying whether the disease is present or not, it will also help us in knowing the borders and extension of the disease. So MRI again is very useful tool, especially in case of salivary gland diseases. So how do we manage? First thing is antibiotics. Give a proper antibiotic which is useful for this condition. Lithotripsy. We have seen that the obstruction can be one of the etiological factor. Hence, breaking of that salivary gland stone or removal of salivary gland stone can be helpful. One, if it is very small salivary stone, then milking of the gland can remove off the stone. Second thing, if it is bigger enough, then we can go with lithotripsy, where lithotripsy, we break the salivary gland inside into smaller pieces, and then by milking of the gland, we can remove it off. And third one is incision. If the stone is very big and lithotripsy cannot be performed, then small incision can be done along the walls of the duct, and removal of the salivary gland stone can be done. Next is dilatation of the duct. As we have seen, obstruction. Obstruction can be because of external structures that are causing constriction of your duct. So in those cases, we can do dilatation of the duct. Duct irrigation is also helpful, and also if none of these treatments are helping, then total conservative parotidectomy has to be performed to relieve the symptoms of the patient. Next, Sjogren syndrome. In Sjogren syndrome, as we know, it is an autoimmune disorder, usually an immune-mediated condition. This Sjogren syndrome is of two types again, primary Sjogren syndrome and secondary Sjogren syndrome. Usually more commonly seen in women, and the swelling appears bilateral, painless swelling usually. And when you're talking about primary Sjogren syndrome, also called as keratoconjunctivitis sicca or sicca syndrome, in this keratoconjunctivitis or primary Sjogren's, usually there will be dry eyes and decreased salivation. Can be either hypersalivation or complete xerostomia. And in secondary Sjogren syndrome, it is usually associated with other conditions such as rheumatoid arthritis and other rheumatic diseases, like you also can see SLE, polyarthritis nodosa, scleroderma associated with secondary Sjogren's. Normally the clinical features are, it is usually progressive condition with severe dry mouth can be seen. Usually it can start with just hyposalivation, decreased in salivation, and it can go to an extent that a patient completely can face complete xerostomia condition. There will be swelling of the glands, usually bilateral swelling, and sicca complex is nothing but your dry eyes and dry mouth. One thing is, this autoimmune condition, when you're talking about Mucoepidermoid, is most commonly can land up into a lymphoma there. However, sometimes in Sjogren's also we can see lymphomatous changes in it. It can convert into a lymphoma. When you're talking about diagnosis, how do we diagnose? Because it is a syndrome, it has a triad of it has a multiple conditions associated with it. So clinically, one patient should have decreased lacrimation, decreased salivation, and if you're talking about secondary Sjogren's, you should also have associated rheumatic conditions. So, how do we check for hypolacrimation or decreased tearing? It is by Schimmer's test. Schimmer's test, what we do is we have a small blotting paper and we place it near the lacrimal ductal opening, and we check for the amount of the amount of tears that are coming out. And absorption of that paper should be 5 mm in 5 minutes. Okay, if it is less than that, then we consider it to be a decreased lacrimation. Rose Bengal score or other ocular dye score can be done, and for checking for hyposalivation, we check for both stimulated whole saliva and unstimulated whole saliva. In unstimulated whole saliva, it is the whole salivary flow. If it is less than 1.5 milliliter in about 15 minutes, then if it is less than that, we can take it as xerostomia. In stimulated salivary flow, if it is less than 0.3 milliliter in about 1 minute, then we again take it as complete xerostomia condition. And parotid psilography can be done to check for any changes within the gland, and salivary scintigraphy. This will also help us to know what kind of disorder it is having or any inflammatory conditions that is usually happening there. Usually all conditions of parotid appear as cold spot, cold spot on the scintigraphy, usually done with technetium pertectinate 99. And you also have to check for autoantibodies. As we already said, Sjogren syndrome is an autoimmune condition, right? Immune mediated. So checking for these autoantibodies within the blood or serum will be helpful. SSA and SSB are pathognomic conditions for Sjogren's. And this is a picture of xylography of Sjogren's, and it usually appear as cherry blossom appearance, or cherry blossom or tree in a winter tree appearance can be our xylographic findings of a Sjogren's condition. Next is Mikulicz disease. It is again an autoimmune condition. Usually it is an IgG4 associated autoimmune condition. And in Mikulicz disease also we have bilateral swelling of the glands with decreased salivation, and it is actually a triad. Mikulicz disease is actually a triad, and this triad is usually a symmetrical enlargement of symmetrical enlargement of your salivary glands, lacrimal gland enlargement associated with dry mouth. And this Mikulicz disease, why it is important? Because it has high propensity to convert into malignant lymphoma. Now, other condition is parotid fistula. This parotid fistula can be it is usually caused because of some penetrating injuries, or if the parotid abscess rupture happened, or if there is incomplete drainage or improper drainage incision of parotid abscess. With this condition, what happens? There is a fistula coming out from the parotid. It can either be an internal fistula or an external fistula. Coming to clinical features, there will be opening into the cheek with a discharge. Also, this discharge is usually increased, especially during meal time. So, how do we treat it? Investigation could be xylogram, because xylogram will give us where the fistula opening is present. And the management is Newman or Seabrook's operation. In this Newman or Seabrook's operation, what we do is we actually put a catheter into this ductal opening, and one another catheter from the fistula where it is opening, and then they connect both of this and they do an excision. Sometimes what we do is, whenever the ductal system is available for ligating, then we do it. And if this condition is not happening, then we go for resection of your auriculotemporal nerve and complete parotidectomy in severe cases. We have another condition called as FREY'S syndrome. FREY'S syndrome is usually caused because of partial trauma to your auriculotemporal nerve. The clinical features of it, actually what is the pathology here is, your parasympathetic nerve fibers are accidentally mixed with your, they get anostomos with your sympathetic nerve fibers. Here, what happens is, this sympathetic are actually supplying to your sweat glands. So, there will be, whenever there is salivary stimulation, there will be obviously sweating from your, from the area where from the skin where your auriculotemporal nerve is supplying. There will be flushing and sweating of the skin over the parotid, especially during the meal. Why meal? Because there is salivary stimulation happening at that particular point of time. There will be cutaneous hyperesthesia, which is usually caused because of your auriculotemporal nerve. And we have another condition called as Sialolithiasis. In this, Sialolithiasis is nothing but, as we have discussed, it is nothing but a stone, salivary gland caliculi or a stone, usually more commonly seen in case of your submandibular gland. Why submandibular gland? Because it is present within your anterior triangle and it is present in the dependent part, and the duct is coming out against the gravity into the oral cavity. And also the submandibular gland duct, that is nothing but your Warthin's duct, is highly tortuous, and the saliva that is produced by the salivary gland duct is highly mucinous in content than serous. So there is more propensity for it for condensing into a sialolith. Normally, whenever a sialolith is present, usually it can vary from different sizes, from some small millimeter to millimeter to few centimeters. Also, it can increase, and usually it is a painful swelling, especially during the meals. The proximal part is usually tender, highly tender in case of this sialolith, and also there will be decreased or almost no saliva from the particular ductal opening. Whenever there is severe obstruction caused because of this sialolith, what happens? It can lead to suppurative condition, also causing sialadenitis of that particular gland. So how do we actually check for it? With bimanual palpation, as I have already described. And coming to diagnosis, we can actually do it with an X radiograph. Occlusal radiograph for submandibular is highly useful, And OPG can be helpful. Your orthopantomogram is helpful in case of your parotid, sialoliths, and also your puff cheek view can also give you a little insight into it. And ultrasound will also be useful in identifying the sialolith there. Sialogram. In sialogram, what happens is there will be void there. When we are actually the dye that has been injected into the salivary gland will not actually fill that space. Okay, so there will be void in the sialogram whenever there is a sialolith. How do you manage it? Milking of the gland, as we described. Sialolithotrypsy can be done, or excision of the salivary gland if at all this if at all the sialolith is present within the deeper lobes of the of the gland, then in those conditions we have to do excision of your glands. So now let us talk about, till now we have seen various non-neoplastic conditions that are occurring. Now let us talk about the salivary gland tumors, the neoplastic conditions. It can be either benign tumors or malignant tumors. First of all, these salivary gland tumors, usually most of the tumors are benign in condition that are occurring in major salivary glands, and about 80% of all these benign tumors of major salivary glands are usually occurring in parotid. When we are talking about the malignant tumors, that is the malignant neoplasms are usually occurring, most commonly seen, about 60% of malignancies are usually seen in minor salivary glands. When you are talking about the classification, the gross classification about these salivary gland tumors, if we are dividing them into epithelial tumors, connective tissue tumors, and metastatic tumors. Coming to these epithelial tumors, the benign tumors are includes your pleomorphic adenoma, Warthin's tumor, basal cell adenoma, and malignant tumors usually involve Mucoepidermoid Carcinoma, Acinic cell carcinoma. We have Adenoid Cystic carcinoma, papillary Adenocarcinoma, squamous cell carcinoma, and differentiated carcinomas. In connective tissue tumors, we have in benign conditions and malignant conditions, and these benign conditions include lymphangioma, hemangioma, fibroma, lipoma, urolemoma, whereas in malignant conditions we have lymphomas, and these lymphomas, most commonly non-Hodgkin's lymphoma is a condition that is more commonly involved in the salivary gland tumors. However, Hodgkin's type of lymphoma can also occur in your salivary glands. Metastatic carcinomas, metastatic tumors can also be seen in salivary glands, and these metastatic tumors of salivary glands usually manifest in lung and also within the bone. Now, when we're talking about this pleomorphic adenoma is one of the most commonest benign tumors. It is the commonest benign tumors. 80% of these benign tumors are pleomorphic adenoma, and among these 80% of pleomorphic adenoma, they occur in parotid gland, and it can also occur in the submandibular gland, and also can occur in upper lip region, minor salivary glands of upper lip. And the common location for this pleomorphic adenoma is usually the tail of your parotid, that is the lower lobe of the parotid gland. These sites, as we have discussed, parotid, submandibular, and upper lip condition, upper lip region. Clinical, when we are talking about the clinical features, this pleomorphic adenoma is called as mixed tumor. Why is it called as mixed tumor? Because apart from the epithelial layer, it also has some amount of cartilaginous, the mesodermal consistent, that is cartilaginous material along with it. Hence, it is called as mixed tumor. There are two schools of thought when we are talking about pleomorphic adenoma. One school of thought is there is really the cartilaginous type of material is present within the this pleomorphic adenoma, and second school of thought is the epithelial lining that is present within this adenoma usually secretes a material, mucinous like material. Thus, on seeing it appears like cartilage. Hence, it is called as pseudocartilage in those conditions. Because in this school of thought, what they say is this pseudocartilaginous material is present in case of pleomorphic adenoma, giving it an appearance like of this normal cartilage. So these are two different schools of thought when you're talking about pleomorphic adenoma. Coming to clinical features, usually it is rubbery in consistency, not fixed to your overlying skin or underlying structure. It is nicely encapsulated, but there are many tiny tiny excrescents that are coming out of this capsule. Hence, when we are actually removing of this encapsulated tumor, if there can be, because of these tiny excrescences that are present, it can result in multiple recurrences even after at later stages of life after your surgical excision of the tumor. It is rubbery in consistency, firm, usually slow growing, and it can grow into larger sizes also. It is because of rubbery in consistency, it is resilient also. Sometimes what happens is because by the amount of different types of tissues that are present within the tumor, consistency varies. For example, it's more amount of cartilaginous material, usually the consistency is firmer in consistency, right? And then origin of the tumor, as I said, can be because by embryonic tumors that are arising from your embryonic wrist, or the mucinous material that has been secreted by your epithelial lining, usually a pseudocartilage. Usually seen in case of women, most commonly seen, and in 4th to 5th decades of life, pleomorphic adenoma is most commonly seen, not adherent to your overlying skin, not adherent to your underlying bony structures. Lymph nodes are usually not involved. However large it grows, does not involve your facial nerve. Remember, if it is involving the facial nerve, then suspect some kind of metastasis, some kind of carcinomatous changes are happening within this pleomorphic adenoma. Usually present below the lobule of the ear. The site is usually below the lobule of the ear. When you're talking about investigations, CT and MRI gives us a very good clear-cut investigation. When we're talking about histopathological investigations for confirmatory, FNAB, that is your fine needle aspiration biopsy, is more preferred when compared to your open biopsy in case of salivary gland tumors. Why not open biopsy? Because there can be seeding of these tumor cells into various places, which can again in later stages can cause multiple recurrences. Hence, this fine needle aspiration biopsy, especially when combined with CT, is of good diagnostic value. And if we have a good cytopathology expert, then we can get this get the diagnosis in a faster way. So no open incisional biopsy is usually recommended in case of this pleomorphic adenoma. Another reason to stop this, why it is not preferred, is because facial nerve damage in such cases is most commonly encountered. When you're talking about treatment of pleomorphic adenoma, usually pleomorphic adenoma is radio resistant, and hence we does not go ahead with this treatment with radiation therapy. So next common thing is excision of the tumor. Second thing is enucleation of the tumor. But in these two conditions, what happens is when you're talking about excision of the tumor, in the facial nerve damage is usually commonly encountered. We're talking about enucleation. As I already said, though it is well encapsulated, the tiny excrescences that are present around the tumor, which can lead to high amount of recurrence. So to exclude these two conditions, we have a very good or better treatment plan, that is nothing but superficial parotidectomy. Superficial parotidectomy, also called as Patty's operation. Here what we do is we actually isolate the facial nerve, separate it, and then take the underlying take all the tumor tissue along with the underlying infected tissue. In case of this superficial parotidectomy, that is a treatment of choice when we are talking about this pleomorphic adenoma. Next common condition is Warthin's tumor, and I forgot to tell you, in case of treatment plan, when you're telling, I said it is radio resistant, right? However, if it is radio resistant also, sometimes in cases like pleomorphic adenoma involving the palate or pleomorphic adenoma, after an excision, if it is present, those tiny excrescences are left over within the surgery. In those conditions, we go ahead with radiation therapy as a palliative form. Okay. However, it is not primary mode of therapy in case of this pleomorphic adenoma. And if it is pleomorphic adenoma is occurring in case of your submandibular gland, we go ahead with excision again. Here, however, you have to take care that you are not hampering or damaging your lingual nerve and hypoglossal nerve. In case of palatal growth, nicely do an excision deep into your the periosteum and up to the bone level. Excise all the tumor tissue from there. If at all the tumor is invading the underlying bone, then the underlying bone also has to be removed in these cases. Now, when you're talking, the next tumor is Warthin's tumor. Again, Warthin's tumor is again a salivary gland tissue inclusions in the lymph node. Okay, hence the name papillary cystadenoma lymphomatosum. what is happening here? The salivary gland inclusions are present within the lymph nodes, resulting in this Warthin's tumor. The most pathognomic feature of Warthin's tumor is it only occurs in parotid gland, and the most common location is lower portion of your parotid gland. Okay, Warthin's tumor pathognomic feature is it occurs only in the parotid and also in the lower lobe of your parotid gland. Here, about 5 to 15% of parotid tumors is again Warthin's tumor, and the lesion is usually benign, well encapsulated, again slow growing and painless. Coming to clinical features of it, it is a painless swelling, slow growing. It is usually, it doesn't grow so big, usually from 1 to 3 centimeters of size, most commonly seen in men, and it occurs usually in 50th to 60th decades of life. Remember, most of the salivary gland tumors are seen in older age group. Bluntly remember, most of the salivary glands are seen in older, middle group or middle age or older, most commonly from 4th decade to 6th or 7th decade. Very rarely they are seen in case of younger children, okay? And has another characteristic feature that it is almost soft or cystic in consistency, and the mucin that is present within will be grainy brown in color. It is usually the mucin is brown in color in case of this papillary cystadenoma lymphomatosum. It is not completely fixed to underlying structure. It can be moved a little. It is not fixed to overlying or underlying structure. Facial nerve is usually not involved, and then lymph nodes are also not involved in case of this Warthin's tumor. Coming to investigations again for Warthin's tumor, we again do xylography can be done, and we take a hot spot. One of the important thing about Warthin's tumor, again a pathognomic feature, is in technetium pertectinate, where all other tumors of parotid gland appear as cold spot, Warthin's tumor appear as hot spot. Apart, you need not go for biopsy also. Warthin's tumor diagnostic feature is hot spot on technetium pertectinate scan. Okay, it is almost equal to your biopsy. However, if biopsy is performed also, we can know Warthin's tumor, and instead of open biopsy again, always prefer a fine needle aspiration biopsy. If that is not possible, then only we will go for open biopsy again in case of your Warthin's tumor. Treatment is again excision, and parotidectomy is again taken when in case of complete severe conditions. Next is Mucoepidermoid Carcinoma. Mucoepidermoid Carcinoma is again usually seen in about 6 to 10% of all of the neoplasms. Mucoepidermoid Carcinoma accounts for 6 to 10% of cases, and this Mucoepidermoid Carcinoma is again a malignant lesion, most commonly involving the minor salivary glands. However, it can also involve parotid, most commonly seen in parotid, and also involves your minor salivary glands. Sometimes intrabony Mucoepidermoid carcinoma can also be seen. This is because of entrapment of the salivary gland tissues during the development stage itself in the your bone structures, especially the jaws. Mandible, especially the posterior part, is again the most commonly involved in case of your intrabony mucoepidermoid carcinoma. And coming back to your mucoepidermoid carcinoma of salivary gland, it is again divided into low grade and high grade based on its aggressiveness. Low grade is usually less differentiated, well circumscribed lesion, and it is usually soft in consistency. Whereas high grade is usually highly aggressive. It is infiltrative. Okay, it will spread into adjacent surrounding structures, usually firm in consistency or hard in consistency. It does not have much of cystic features associated with it, and it is again divided into based upon the consistency: solid, cystic or semi-cystic. Okay, and histopathologically or histologically, based on the type of cells that are present, it is again divided into 4 types. One is clear cell type, one is intermediate type, one is squamous cell type, and one is mucin producing type. This intermediate type is usually a precursor of your mucin producing type and squamous cell type, whereas clear cell type is usually most predominantly we see clear cells in case of this mucoepidermoid carcinoma. And it does not, coming to clinical features of it, usually well circumscribed, as encapsulated. If it is low grade, it is well circumscribed, and if it is high grade, it is usually infiltrative, slightly firmer in consistency, sometimes fixed to underlying structures, usually painless, does not have any pain unless secondarily infected or secondarily ulcerated. The nerves, facial nerve usually is not involved. I mean, there is no facial paralysis usually. It is fixed to underlying structures, and lymph nodes sometimes are fixed, and also you can see metastasis of mucoepidermoid carcinoma, especially to lymph nodes and lungs. So lymph nodes in mucoepidermoid carcinoma are usually stony hard in consistency, as similar to your any other carcinomas, and are fixed with your underlying structures. So treatment again, surgical excision. If needed, radiotherapy has to be given, and chemotherapy also will be useful in case of when it is usually when the surrounding margins are left over, or if surgeon has a doubt that there are some remnants in it, then chemotherapy can be given post surgical therapy. Now coming to your adenoid cystic carcinoma, also called as cylindroma. This adenoid cystic carcinoma is usually a tumor which is affecting your ductal cells, most commonly seen in submandibular gland, however also associated in case of parotid, and also your minor salivary glands. Common sites, as we said, submandibular gland is most commonly involved here. One important or interesting thing of this adenoid cystic carcinoma, it can also involve trachea, your pharynx, your bronchi, paranasal sinus. These structures can also be involved in case of your adenoid cystic carcinoma. This adenoid cystic carcinoma is a slow growing one. Usually there will be pain, however local pain, and it is involving your adjacent structure. It invades your perineural lymphatics. When it is invading the perineural lymphatics, it is usually leading to anesthesia of the skin, and because of this perineural invading perineural lymphatics, what happens? They are usually firmer in consistency or hard in consistency. Lymph nodes are usually hard and are fixed to this adenoid cystic carcinoma has fixity. It is usually fixed to underlying bone or fixed to underlying periosteum. Investigations, again we have regular investigations like cyelogram can be taken. We can take CT and MRI. MRI is usually your best investigation. Usually also gives you the margins that are being present along with it, and associated with it radical surgical therapy is the treatment of choice. Next is acinic cell adenocarcinoma. This acinic cell adenocarcinoma usually seen in parotid. Women are more commonly involved again, 5th to 7th decades of life. Again a slow growing one. It is usually very rare and low grade malignancy. Acinic cell carcinoma is usually low grade malignancy, does not pose much of a risk. Usually the swelling is again round or ovoid in shape, and it involves the lymph nodes. Investigations again similar, cyelogram. Your MRI again gives you a better diagnostic value for it, and treatment is again resection. You have to do surgical excision. Finally, carcinoma of parotid gland. This carcinoma of parotid gland is similar to like any other malignant tumors, and history is very important. Here we can it will ask the patient for general history like loss of weight, loss of appetite, other constitutional symptoms associated with it. Usually in the carcinoma of parotid gland, it is firm in consistency. Indurated edges or margins can be seen. The swelling is usually diffuse, infiltrating type. It can involve the adjacent facial nerve, resulting in anesthesia or paresthesia. Lymph nodes are also involved. Stony hard lymph nodes can be palpated. They are usually enlarged, and consistency is stony hard, and they can be fixed to underlying structures. Fixity to underlying structure, the tumor fixity to underlying structure is also seen, and also it can also skin over the swelling can also be fixed. And very rarely you see the inflammatory findings. However, pain can be present because of the fascia is very tight over the parotid gland, right? So because of its fast growing, this carcinoma of parotid is again a fast growing aggressive tumor. Because of this, what happens? The tumor cannot expand the skin that is present in the surrounding region, resulting in tenderness or pain. Coming to examination, we can see a unilateral swelling, usually diffuse swelling which is harder in consistency, lymph node involvement, paresthesia can be seen. Based on the various clinical symptoms, again we can come to a conclusion that it is a carcinoma of parotid gland. And treatment of malignant tumors, how do we treat is primary thing is surgery, either total parotidectomy in case of severe conditions, especially like Mucoepidermoid Carcinoma or Acinic cell carcinoma or Adenoid Cystic carcinoma. Mostly as Adenoid Cystic carcinoma, we go ahead with radical neck dissection, and superficial parotidectomy with radium implantation is also useful in some of the malignant tumors. Radiotherapy usually not prescribed or not followed because most of the salivary gland tumors are radio resistant. However, in case of excessive margin, in case of infiltrative margins, and surgeons will write that margins of the infiltrating lesions are almost near to the surgical margin, then in those cases we do is radiotherapy, usually with cobalt, and chemotherapy also as palliative therapy, or post if the surgeon feels that there are any remnants of your tumor, we go ahead with chemotherapy, most commonly 5-fluorouracil, or we can go ahead with methotrexate. However, cyclophosphamide is a drug of choice in case of salivary gland tumors, for giving better prognostic value. So these are about various non-neoplastic conditions and neoplastic conditions of your salivary gland. We also have seen most common neoplastic conditions in both benign and malignant tumors. Hope this gives you a better insight into various salivary gland diseases. Thank you.